It's to you, sir.
Thank you very much, Comfort, for that kind introduction. And grateful and happy to be here today to discuss surgery for colorectal cancer. I spent some time with Dr. Alatise. He's a good friend of mine, and I'm happy to see him here. So I'm going to go straight to surgery. It's going to be a bit more technical than what has been discussed. And the goals of surgery for colon cancer is essentially to achieve long-term survival and even cure patients who have colon cancer. Sometimes we operate on patients based on symptoms. Patients will come in with abdominal pain, intestinal obstruction, bleeding, and of course, those patients will need surgery. Sometimes we operate on patients who have metastatic disease, especially colorectal liver metastasis. And of course, surgery plays a very important role sometimes in terms of palliation. So I'm just going to go and talk about each one of this. So before we operate on cancer patients, colorectal cancer patients, we need to have appropriate staging. And we need abdominal imaging. We need a CT scan of the abdomen and the chest, possibly even an MRI. If the patient has rectal cancer, we need to stage the rectal cancer locally by doing a pelvic MRI. Unfortunately, I think many of our colleagues who are listening here from Africa, probably this is what you see. Many of our patients present with intestinal obstruction, with a late diagnosis, and some of them have peritonitis by the time they come to us. This patient had gangrene. We had to resect the bowel, and we ended up with a colostomy. So this is unfortunately a very familiar scenario. And I think what, as Dr. Isaac Alatise has described in his presentation, screening, I think it's going to be very important in trying to prevent such catastrophic outcomes. So when it comes to cure, curative intent surgery, the aim is to remove the tumor, the tumor-containing segment of the bowel with adequate margins, and including en bloc excision of the mesentery, which has all the lymph nodes and the vessels that supply the tumor and the part of the colon. And of course, this depends on the location of the tumor. So I'm just going to describe a couple of, just a bit of the anatomy that shows that the right colon is supplied by the superior mesenteric artery branches, and the left colon is supplied by the inferior mesenteric artery branches. And the lymph node drainage also depends on the location of the tumor. And as we know from all the studies that have been done on colorectal cancer, lymph node status of the patient has a significant prognostic prognostic factor. And we operate on these patients and try and get as many nodes as possible. Minimum, we should get 12 lymph nodes for us to be able to adequately stage the patient. So, so if the tumor is in the right colon, we will typically do a right hemicolectomy. Tumor in the proximal transverse colon will require an extended right. Yeah.
Sorry for cutting you short. The audience is asking about your PowerPoint presentation that we're not able to see it. Are you able to share it?
Oh, I think sorry, I thought I was sharing it.
No, it's not being shared. Again. Kindly share it with us. Thank you.
Oh, I'm so sorry about that. I thought I was sharing it the whole time. There.
Perfect. We can
Can you see it now? Sorry, sorry. I thought I was sharing it the whole time. So I've gone through all these things. I'll just go through this, and this is what we see. Patient with peritonitis. This is one of the commonest presentations because of lack of screening. And of course, the aim is to remove the tumor-containing segment of the bowel with en bloc excision of the mesentery and the nodes, and that depends on the location of the tumor. And if the patient has a right colonic tumor, we will do a right hemicolectomy. Patient with a tumor that is located in the proximal transverse colon will require an extended right hemicolectomy. If the tumor is in the transverse colon, we will do a transverse colectomy. Tumor that is very high up there, that is distal transverse colon, will require an extended right hemicolectomy and a bit of left hemicolectomy. Tumor that is in the splenic flexure would require a left hemicolectomy, and the sigmoid tumor would require sigmoid colectomy. So this is just an example of a laparoscopic right hemicolectomy procedure. This patient has a tumor in the right colon, and this is already been tattooed colonoscopically before the surgery, so that we can be able to identify this during laparoscopy. And this is the ileocolic pedicle, the right colonic blood supply that we will dissect right there. And we'll go below the colon, all the way down, take the duodenum down, go around the omentum, and eventually do a lateral dissection of the colon. This allows us to completely free the colon together with the mesentery, and then we are able to take as many lymph nodes as possible. We typically ligate the superior-mesenteric, the ileocolic artery just at the origin of the superior-mesenteric artery, where it comes with the superior-mesenteric artery. And then we will do a right iliotransverse anastomosis. In rectal cancer, this is a totally different ballgame. So usually depends on what we see during an MRI. As I said earlier, MRI is extremely important in determining the local extent of disease in patients who have rectal cancer. And the most important thing is the circumferential resection margin that we need to ensure whether it's breached or preserved, because that has significant, we'll decide on what to do with the patient in terms of whether this tumor has breached the circumferential resection margin. Unfortunately, we do get patients who have a tumor that is involving the sphincter muscle and the levator ani, and that, of course, these patients most likely will end up with an abdominal resection with permanent colostomy. But almost always, patients who have rectal cancer, especially stage 3 disease, will almost always get neoadjuvant chemoradiation therapy. When it comes to rectal resections, again, it depends on the site of the tumor. If the tumor is proximal rectum, we will do an anterior resection, which is essentially taking the sigmoid colon and part of the rectum, the proximal part of the rectum. If it's a low or mid-rectal tumor, we'll do something called a low anterior resection, and we do maybe a coloanal or a low colorectal anastomosis. And the problem with this usually is, there's high risk of anastomotic leak, which I'm going to talk about that in a few minutes. The other thing about the surgery for rectal cancer is that we need to make sure that we have adequate length of colon that will reach the rectum. And that means that we might have to get the superior-mesenteric vein very high. Typically, we do take the IMA just at the origin, so that we're able to incorporate all the lymph nodes. And we'll be able to take this part of the colon down into the rectum, into the rectal anastomosis. This is the spleen, so these patients most likely will require a splenic flexure mobilization. So we'll dissect around the spleen, the pancreatic ligament, splenocholic ligament, and the pancreatic ligament. That will actually be able now to allow this part of colon to go down for tension-free anastomosis. The other very important concept when it comes to surgery for rectal cancer is the concept of total mesorectal excision. As you can see from this MRI, this is this line that you see here. This is the mesorectum that is carving along the sacrum. We need to make sure that we incorporate this into the specimen so that we are able to get all the lymph nodes which are within the mesorectal fascia. This is a laparoscopic view of the same of the total mesorectal excision. We need to make sure that all the nodes go with the rectum, and we have to be careful not to enter into the presacral fascia during surgery because of the risk of bleeding. And typically, we anastomose rectal anastomosis using stapler. This is widely available here in our country. It's very difficult to do deep pelvic anastomosis handstand fashion, and we almost always use stapler to anastomose the rectum to the distal rectum or even the anus. For patients who have low rectal anastomosis, especially patients who have received neoadjuvant chemoradiation therapy, we almost always bring out a diverting loop ileostomy. The reason why we do that is to protect the anastomosis. And it's not that this reduces the risk of anastomotic leak, it's just that if a patient gets an anastomotic leak, then it's easier for us to be able to manage that leak. We may not have to take the patient to the operating room if the patient has diversion already done. However, if the patient didn't have a loop ileostomy and gets an anastomotic leak, then we will end up operating on that patient. This is a case of an anastomotic leak. You can see the staple line there, which is disrupted. There's free air in the pelvis. There's a lot of fluid in there, and this is the intraoperative picture of a leaked anastomosis. It's a catastrophic thing. Unfortunately, it's something we see in colorectal surgery, and we just have to live with it. We have to make sure that we try everything possible to prevent it, but it's something that we see. And if we have diverting loop ileostomy, then that makes it easier to control the sepsis. With sometimes patients postoperatively can get an anastomotic stricture, and typically that will undergo endoscopic dilatation. Finally, just last minute discussion on laparoscopic versus open resections. This is a big topic, and there are a lot of studies which have been published in the last 10, 15 years, very high quality randomized control trials that have shown that laparoscopic colectomy for cancer is as good as open in terms of the long-term oncological outcomes. And it also provides some very good short-term benefits, especially less postoperative pain, earlier return of bowel function, and shorter hospital stays. Luckily, in our setup here, we have at least 4 or 5 different institutions within Mombasa that have laparoscopic equipment. And I think as time goes by, a lot of hospitals in Kenya are actually trying to do laparoscopic procedures. Sometimes we have patients who have unresectable disease, especially in the pelvis. These patients have a hostile pelvis, and we will just do a palliative bypass. So this is another role for surgery. And in some cases, if a patient has a distal colonic obstruction or rectal obstruction, for example, unfortunately, we see quite a bit of that, as Isaac has shown, and from his studies, that we do get quite a bit of stage 3, stage 4 disease. Sometimes patients who are completely unresectable will present with the end stage disease that is unresectable. So those patients will end up with a diverting colostomy. So that is one of the ways we can palliative surgery that we do. And with that, I'd like to thank you all for inviting me. And hopefully when coronavirus ends, you're all welcome to Mombasa.
Thank you, Dr. Mohammed, for the invite. We'll definitely be yeah. Thank you. We'll definitely come through. And thank you for the presentation. It was very detailed and thorough. I think now I can perform surgery. Of course not. It was very detailed. So our next presenter is Dr. Rich. So I just want to give you a little bit on Dr. Rich and what Dr. Rich is all about. So Dr. Handler Rich is an associate professor of medicine and also medical sciences at Warren Appett Medical School of Brown University faculty. He has been a member of the Warren Appett Medical School of Brown University since 1992. I don't think I was born by then. Dr. Rich received his medical degree at Columbia University College of Physicians and Surgeons, performed his internal medicine residency at Boston City Hospital, and also his fellowship training at Brown Medical School. He has served as Chief of Gastroenterology Section at the Providence VMAC and Director of Endoscopy at Rhode Island Hospital. He's currently the medical director of Brown Medicine Endoscopy Unit, and director of the GI Clinic at Rhode Island University, clinical director of the Division of Gastroenterology at Brown Medicine, and the quality director for Gastroenterology Division. He is section leader of the Appet Medical School second year GI pathophysiology course, teaches third and fourth year students in the medical and longitudinal clerkships, is a former chair of the medical school curriculum committee, and is actively involved in training internal medicine residents and GI fellows. Research interests have included understanding signal transduction in smooth muscle dysfunction in the esophagus, visceral hypersensitivity, imaging, hence endoscopic evaluation of colonic polyps, polyp detection rates in endoscopy, use of CT angiography in lower GI bleeding, use of computer-assisted sedation for endoscopy, studies on interventions to improve colorectal cancer screening outcomes, and utilization of anesthesia resources in endoscopy. His clinical interests include clinical esophagology with an emphasis on esophageal reflux disease, esophageal motility disorders, and Barrett's esophagus, as well as general gastroenterology, including colorectal cancer screening, peptic ulcer disease, and irritable bowel syndrome. He has worked to expand the role of technology in clinical gastroenterology via the use of ambulatory telemetric pH, capsule endoscopy devices, and computer-assisted personalized sedation. So right about now, he would discuss a global overview, bowel preparation for colonoscopy, a history of bowel preparation, and current recommendations. To you, Doc. Thank you.
There we go. Thank you for that wonderful introduction, Comfort, and thank you to everyone. I'm very honored to be with this amazing group of researchers and clinicians this morning or this afternoon or this evening, depending upon where you are in the world. So good day to all. And a special thank you to Dr. Akwi Asimbang, who I have the pleasure of working with every day, who's one of your co-founders and obviously goes to great lengths to make sure these programs are very informative, topical, and educational. So thank you to her. I was asked to talk about preparation for colonoscopy with a history and current recommendations. I'm going to try to make sure this is running here. Everyone can see that? Yes. Okay. So we'll talk about history of colonoscopy and colon cancer screening history, and spend most of the time talking about bowel preparations, including the importance and goals, a brief historical overview, what types of preparations exist, bowel preparation as a quality measure, the role of diet, how to improve compliance. We'll try to give a summation. I'm trying to do this in 10 minutes. So the history of colonoscopy and endoscopic evaluation dates back to as far as 1805 with rigid sigmoidoscopy. Flexible sigmoidoscopes were introduced in the early 1960s, and the first flexible colonoscopy was performed in the mid-1960s by passing a tube through the mouth, out through the anus, grabbing a scope, pulling it back through via a traction pulley system, which sounds fascinating. It took several days to accomplish that. The first actual retrograde colonoscopies were accomplished by Dr. William Wolfe and Hiromi Shinya in New York using colonoscopes in the late 1960s, and they were able to demonstrate the feasibility of endoscopic polypectomy. And by the 70s, longer colonoscopes with suction controls, air water infusions were introduced. And by the 80s, we were interested in seeing the advent of video colonoscopy. Colon cancer screening historically also has been something that occurred during the last century. In 1927, a group at St. Mark's were able to demonstrate that colon cancer was associated with adenomatous tissue. In the 1930s, Duke's at St. Mark's in London was able to start a staging system which showed that better patient survival accompanied earlier stages of diagnosis. Morrison, who was a radiologist at St. Mark's, was able to describe the polyp cancer sequence, and in the 1980s, Vogelstein at Johns Hopkins demonstrated genetic alterations which accompanied the transition of polyps to cancer. This information was then put into practice in terms of implementation of colon cancer screening. Starting in the late 1940s, people started doing rigid sigmoidoscopic studies, and the first study from 1948 was presented 25 years later, showing an 85% lower incidence of colon cancer. Again, studies conducted through the 60s and into the 70s, where they started using guaiac-based fecal testing, where a study started in the 1970s, first reported beneficial results in 1993 in the New England Journal of Medicine. A study called the National Polyp Study was studied at several centers in New York in the 1980s through the early 1990s, and they were able to start reporting out in the late early 90s or even as late as 2012, reductions in colon cancer incidence, and then a reduction in colon cancer mortality in patients who underwent colonoscopic polypectomy. It was very clear that you could find colon cancers early by intervening, by screening, and it also became very clear that by removing polyps, you could reduce incidence and mortality as well. So bowel preparation is an essential part of a high quality colonoscopy, and without a good bowel preparation, we're not going to get a good view of the entire colonic mucosa. It's very clear that if you have good cleansing, you're going to have a greater ability to detect the polyps that our other colleagues have demonstrated this morning. The polyps less than a centimeter in size, obviously are a little bit less important than the ones greater than a centimeter in size, but we tend to think that greater than 6 millimeters is probably important to detect for maximizing the benefit of screening. And so retrospective studies have shown that good preparations are important to do that, both in the United States and Europe. And it's very clear that the colon preparation is probably one of the biggest obstacles to patient compliance. Most patients who refuse colonoscopic screening identify the bowel prep as the most objectionable portion because the taste is unpleasant. There are side effects of the preparation. There are severe dietary restrictions, and getting your bowel cleansed does interfere with your daily life. So if you have a poor bowel preparation, you're going to have a number of difficulties. You're going to have poor difficulties with technical performance. In the UK, 1 in 5 incomplete failures or incomplete colonoscopies were caused by a poor preparation. And in France, even though only 4% of procedures were incomplete, most of those, or at least a third of those, were due to poor colon cleansing. We think that having poor colonic cleansing increases the cost, so that you may have to repeat the colonoscopy or increase the surveillance interval. If you have a poor preparation, you may wind up with decreased physician efficiency because the procedures take much longer to do. The patient may need to require additional cost sharing or payments for the examinations. There may be additional financial risks if the preparation is poor. One of my fellows who's out in Texas now actually did a study recently showing that if greater than 13% of colonoscopies have to be repeated because of a poor prep, they're no longer cost effective. We worry in the United States a lot about medical legal risks, about missing lesions. And obviously, the poorer the preparation, the higher the rate of complications. We found that in one study, greater than 20% of patients who had inadequate colonic preparation failed to follow the preparation instructions. But there are a number of other independent predictors of inadequate colonic preparation, and those include a later start time of the day, the failure to follow the preparations, the inpatient status, the procedural indication for constipation, use of tricyclic antidepressants, which are anticholinergic agents and slow the bowel, being male, and having a history of cirrhosis, stroke, and dementia. The use of psychotropic medications, opioids, obesity, diabetes, and Parkinson's were also increased risk factors. And there are a number of socioeconomic risks, including being male, single or widowed, having a low health literacy, having language barriers, a low household income, and lower educational level. So historically, I couldn't find a lot of information about the history of bowel preparation, but it's obviously been in use for decades. Initially prior to radiologic procedures such as IVPs and prior to surgical procedures. And the traditional bowel cleansing consisted of dietary restrictions, oral cathartics, and enemas. They might have patients on low residue diets for 3 days and using magnesium citrate or senna extracts and using tap water or phosphate enemas. These regimens, though, required a long time commitment. They interfered with the patient's daily activities, and many of them introduced fluid and electrolyte disturbances. At some point in the 70s or so, as colonoscopy was coming online, preparations using high volumes of gut lavage with 7 to 12 liters of a saline or electrolyte solution were proposed, but these were associated with severe fluid and electrolyte disturbances and poor patient tolerance. So in order to prepare the colon, we have some ideal standards, ideal goals. We want to empty the colon of fecal material to allow the endoscopist to see the entire surface. We'd like to do this rapidly. We don't want the preparation to induce macroscopic or histological alterations. We want it to be satisfactory for patients to take in terms of taste and volume, palatability, tolerability. We need it to be safe, not causing many shifts in fluids or electrolytes. And ideally, it should be affordable as well. So there are a number of options that are currently available. There are osmotic laxatives, including sodium phosphate, magnesium citrate, and mannitol. There's polyethylene glycol alone as a 4-liter preparation, either as a full dose the night before or as a split dose the night before in the morning of the exam. Many people have shifted now to a lower volume 2-liter polyethylene glycol combined with laxatives or an additional osmotic agent or the use of stimulant laxatives. Sodium phosphate preparations were very big for a while. These tended to be low volume solutions or could be administered in tablets, and they osmotically drew water into the lumen. These were, though, able to induce a lot of significant water and electrolyte shifts. They needed to be diluted. They had to be accompanied by a large volume of fluid intake. They had a lot of side effects, including nausea, vomiting, abdominal pain, and bloating. And there were a large number of adverse metabolic effects to these, including hypokalemia, hypocalcemia, hypovolemia. And so they needed to be avoided in many subgroups of patients, including the elderly, congestive heart failure patients, liver or renal insufficiency, people with inflammatory bowel disease. And so some markets have actually removed these from use. There are oral sodium sulfate preparations, which have a similar mechanism with a somewhat better safety profile. Historically, polyethylene glycol was first synthesized in 1859, demonstrated to be non-absorbable in 1947, and was actually used for looking at transport mechanisms in the colon. It was actually helpful in the development of oral rehydration solution and sports drinks like Gatorade. It was found in the 1980s to demonstrate a strong osmotic pressure across the small intestinal mucosa. And in 1980, after attempts were made to use mannitol for osmotically balanced solution, it was substituted. And the reason that mannitol was removed is that it may be fermented by colonic material and yield potentially explosive gases. And so by adding some potassium chloride and bicarbonate, the net absorption of water and electrolytes was near zero. And so their versions of these included Go Lightly or Colite and New Lightly or Trilite, which were sulfate free. Just to mention the colonic gases, hydrogen and methane are present in the colon. They are combustible. Using non-absorbable sugars like lactulose or mannitol, which were present in preparations prior to 1980, could produce these gases and may be present with oxygen and the heat source to trigger combustion. So thankfully, we have never seen this in my unit, but it is well reported. So bowel preparation options, a standard 4-liter PEG-based formulation is generally safe and effective, but there's poor compliance, typically because of the salty taste or sulfate odor. Upwards of 15% of patients are unable to complete the preparation. It's been found that splitting the dose in the morning of the test and the night before is more effective. Again, there are a number of side effects which are common, but it does not cause substantial fluid and electrolyte shifts, and it's a much safer preparation for patients with electrolyte imbalances, renal liver insufficiency, congestive heart failure, or liver failure. Stimulant laxatives, there are a number available, including bisacodyl, magnesium citrate alone, sodium picosulfate with magnesium citrate, and various combinations of these, picosulfate with magnesium oxide, sodium sulfate. Many of these are available as pre-prepared preparations with a variety of brand names. They tend to be more expensive for the patients. Again, sodium sulfate in the form called Suprep, and then using PEG with Senna or high-dose Senna alone, oral stimulant type laxatives. Low volume PEG, you can use 2 liters of PEG with bisacodyl or magnesium citrate or ascorbic acid, and some of these things are felt to improve the taste. And obviously, we have been using bowel preparation as an independent quality measure. We've found that the adequacy of the bowel preparation impacts the cecal intubation rate, the adenoma detection rate or miss rate, particularly for right-sided sessile serrated polyps, the cost of the procedures, the physician efficiency, the difficulty of the procedure, and adherence to screening intervals. So this is considered a quality measure in the United States, and we feel that this is really a shared responsibility between the colonoscopist and the patient. There are screening scales or rating scales to determine how good the preparation is. And the one that we tend to use most commonly is this Boston preparation scale, because it looks at the quality of the preparation after washing and suctioning. We still need to figure out exactly what it means, but typically if it's a low quality preparation, the patients are brought back sooner to make sure we do a good screening for them. Is one prep better than another? There are numerous head-to-head comparisons. Most are non-inferior to one another. And some can be better and worse at the same time. So they may be better tolerated, but have a slightly poorer prep, or be better prep, but be slightly poorer tolerated. So I would say that one is not necessarily much better than another. The role of diet is important. Too many dietary restrictions lead to decreased patient satisfaction and less compliance. And it's very clear from randomized controlled trials that using a low residue diet is just as good as a clear liquid diet the day before. Other adjuncts to bowel preparation, including enemas, metoclopramide, are probably not useful. There's some suggestion that simethicone may reduce bubble formation and foaming. I did find one study using lukewarm saline and yoga postures. That was a study done in Brooklyn, which is interesting and being piloted. Lubiprostone has no added benefit. So we need to change the perception of colonoscopy preparation. As I was going online, I was finding a number of memes and things. Here's the devil saying the colonoscopy isn't your eternal punishment, the prep is. Here's one saying the prep is so delicious, I think I'll drink another, said no one ever. Here's someone who has a t-shirt saying they're a colonoscopy prep survivor. And lastly, here's one comparing the colonoscopy prep to this horrible year of 2020 that we just went through. So we have to change the perception, and again, we have to change the compliance as well. So as we use preparations that are more palatable, if we can reduce the volume of fluids, limit the dietary restrictions, improve patient education, and use split dose preparations, all of these have been shown to improve compliance, tolerance, and the willingness of the patient to come back as well. Education is super important, direct education by nurses and physicians. You can use cartoons, phone calls, social media apps, text messaging, a variety of smartphone applications will all enhance the standard instructions. And most importantly, having language concordant navigators and language concordant instructions is going to be very important for multinational patients. The instructions should be easy to follow to improve compliance and preparation. I'll just mention the cost. This is a recent data table from the US showing the cost of preparations. And you can see you can use standard PEG at about $16 to $20. You can use a brand name solution, $250 US dollars. Again, more expensive is not better. And again, magnesium citrate, for example, is much less expensive. So take home points: an optimum colonoscopy requires an optimum bowel preparation. Split dose oral preparations optimize bowel cleansing, and ideally the second dose should begin about 4 to 6 hours before and be done by 2 hours before the colonoscopy. Lower volume preparation will improve compliance without sacrificing quality. A low residue diet may be as good as clear liquids. Clear patient instructions and language concordant patient navigation will improve compliance and the quality. And we need to ideally customize our preparations to the needs of the patient. We have to balance the efficiency, the cost, safety, and tolerability of the patient's health, their conditions, their preferences, and also optimize the regimens with predicted previous poor preparation, so we're not bringing them back multiple times. Again, this is Colorectal Cancer Awareness Month. Colon cancer screening saves lives, and we are actively promoting this both in the US and worldwide, and I thank you for your time.
Thank you. Thank you very much, Dr. Rich, for this very informative session. So for those of you joining us right now, we are currently talking about colorectal cancer in Africa, and we have experts from around the world who are breaking down the various aspects of colorectal cancer in Africa. So right away, we'll move on to our next presenter, who is Dr. Lewis Banda. Dr. Banda is a senior medical superintendent and consultant oncologist at the Cancer Disease Hospital, Zambia. So today he's going to discuss with us the role of chemotherapy and radiation oncology in the management of colorectal cancer. So Dr. Banda, you have the floor.
Okay, thank you very much for the introduction. Thank you, Akwi and the team, for inviting me to do this presentation. I'm Dr. Banda, clinical oncologist, as well as the senior medical superintendent for Cancer Disease Hospital. This is my hospital. This is a wing where we admit our patients. We've been in existence since 2006, and we are the only cancer treating facility in the country. Coming to the topic, for the time given, I will try to be brief, but I'll give as much information as possible. From the outset, I should say, the management of colorectal cancer is one area where you have to have multimodality being used. You have surgery, you have chemotherapy, you have radiotherapy that you have to combine in your management of the cases. Multidisciplinary teams are encouraged in the management of colorectal cancer, surgery being the primary treatment modality. There is limited data when it comes to the management of the colon cancer. I've split the management itself into colon as well as rectal cancer management. So in colon, there's some limited data for the use of radiotherapy in colon cancer, and colonic cancers likely you are going to get distant metastases than local recurrences. And the benefit of adjuvant chemotherapy has been demonstrated from various studies that have been done over the course of years. And the benefit of adjuvant chemotherapy is very clear with those cancers that are stage 3. For chemo in stage 2 cancers is dependent on having the presence of the high-risk factors. And the high-risk factors that have been identified include inadequate sampled lymph nodes. Remember, as the surgeon had said, you require at least 12 nodes for you to say you have done a good lymph node dissection. And T4 lesion is also a high-risk factor. Perforation, obstruction at the time of surgery, and poor differentiated histology is also a risk factor. If we start managing the cases, it will go by stage. In stage 1, which is T1 and T2, N0, M0. In these cases, post-surgery, there's no adjuvant therapy that is recommended. And for those in stage 2, which is a T3 node and T4 node, M0, chemotherapy is only indicated when you have those features that I mentioned earlier on. And there are these studies that have been done, which have shown that there is an improved outcome when you add chemotherapy when there is high-risk factors, including the IMPACT B2 study, the QUASA study, and there's a systemic review which was done, which showed that there's improved outcomes when you add chemotherapy in stage 2 with high-risk factors. When it comes to stage 3, where there's a clear improved outcome with addition of chemotherapy. The adjuvant oxaliplatin-based chemotherapy is what is becoming standard. This was shown from the Mosaic study, and NSABP CCO7 also confirmed that there's efficacy with addition of oxaliplatin to 5-FU. Initially, the cases were receiving post-surgery would just give 5-FU and leucovorin, but with addition of oxaliplatin, there's an improved, efficacy. And now, capecitabine plus oxaliplatin is another recommended option. Capecitabine is an oral 5-FU that can be given, which is coming also to the front of management of these patients. Irinotecan-based therapies are not considered, for adjuvant treatment because they don't show any benefit. And also targeted therapies in the adjuvant setting have shown no benefit as such. This is my new hospital, which I'm proud of, just showing the pictures of the inside of the hospital. When it comes to metastatic colorectal cancer, chemotherapy first-line drugs that have been used, we include regimens such as FOFOX, FOLFIRI, and there are various studies that have shown that FOFOX is a better option over irinotecan-based chemo regimen. And there are also triple regimens that have come, and these have shown improved response rates and also progression-free survival and also overall survival that have been used. In some cases where the patient condition is not so good, you can use single-agent capecitabine, and there are several other regimens that have been used. But the use of targeted therapies works well also in patients who have metastatic cancers. So bevacizumab, which is an anti-vascular endothelial growth factor drug, in addition with regimens that I've mentioned earlier on, FOFOX and FOLFIRI, you can use in a metastatic setting. And for those that have KRAS wild type, you can use cetuximab. Panitumumab has been used, which is the anti-epidermal growth factor receptor drugs. And those are the studies that have been used to verify the efficacy. In the second line setting, you can alternate the oxaliplatin-based regimen with the irinotecan-based regimen. And also you can use drugs such as bevacizumab, which is the anti-VEGF drug. There's been use of zevafibrocep in some instances, which is a VEGF trap with irinotecan naive patients, and who have failed on oxaliplatin-based therapies. In the third line situation, you can use single agent cetuximab or panitumumab. You can use regorafenib which is an oral multiple kinase inhibitor. When it comes to the management of rectal tumors, the neoadjuvant chemoradiotherapy, has become like standard in the care of colorectal cancers, and the degree of response of these cancers to the neoadjuvant treatment shows, whether the patient is going to do well or not. So it shows In those that have done very well with a complete response, there is also some studies that are showing now that probably you cannot add, you don't need to do the surgery, but the standard has been that we should do surgery after the chemo RT. But there are new studies that have come that are showing that with the use of chemo RT in the preoperative arrangement, some of those patients that have complete responses should not have surgery. You can continue monitoring them, and if they progress, you can use surgery as salvage. The advantages of using pre-op chemo RT over use of post-operative RT is that you can downstage the tumors, you can improve on resectability, and you have improved tolerance for both acute and chronic side effects. And then you have the potential for sphincter preservation, especially in those tumors that are distal in the rectum. And surgery still remains mainstay for curative treatment for these tumors. And the studies that have shown evidence include the MRC CR7, as well as the German rectal trial, which used the short course radiotherapy without chemo, 25 gray in 5 fractions, or the German trial, which used the long course with chemo radiotherapy up to 50.4 gray at 1.8 gray per fraction with concurrent 5FU based chemotherapy. And this is what has been used as standard. The short course is mainly used in Europe, and America tend to use the long course chemo RT. And when we are managing these tumors, we still can give just, you can still just have surgery for those who are like T1, T2, and N0 with no, you know, bad prognostic features. So those that have T1, they tend to have very low involvement of lymph nodes to the tune of 5 to 10%. And those that are T2, the percentage for lymph node involvement is quite high, it's 20 to 35%. And those with T1 lesions have an excellent result with just local excision alone. And for those with T2, has increased local failure. And for these patients, you have to watch out for the good prognostic features. That is, the grade of the tumor should be 1 or 2, and then the margins should be more than 3 millimeters. There should be no lymphovascular invasion, and there should be no regional lymph nodes on imaging more than 2 centimeters. And if these features are there, if these features are not there, then this patient will need post-op radiotherapy. For the management of T3, T4, and the N1, preoperative RT, as I said earlier on, is the standard of care. And then infusional chemotherapy is what is being given these days. And this is associated with lower local recurrences, as well as reduced acute, as well as chronic toxicities of radiotherapy. And also there's improved compliance and high sphincter preservation. Overall survival between pre-op chemo RT and post-op chemo RT is equal. And resection of the tumor should be done usually at 6 to 12 weeks after the chemo RT. The other roles for radiotherapy in this tumor is for use in metastatic situations where the tumor has gone to the brain, to the spine, to the bones, or there's bleeding or pain, you can palliate using radiotherapy, which is a good intervention that you can use in such situations. Thank you very much.
Thank you. Thank you very much, Dr. Banda, for this very informative presentation. We are very grateful, and we have actually learned a lot. Following up from Dr.
Apologies for that. I think we're just having a problem with the network. David will join us soon. So following up from Dr. Rich, would now want to hear from the panelists how is bowel preparation from their country, how it's conducted, and how they advise their patients. So we've got a number of panelists who are going to just explain to us how bowel preparation is done in their country. To start with, we're going to start with Professor Mohado Gab, who's a professor of medicine, gastroenterology at Tanta University. Professor, please go ahead and just share in a space of about 2 minutes. As we wait for Professor, maybe the next panelist can go on. I think he's not on currently. So the next one on the panelist is Dr. Brighton Sonkolo, who's the head of clinical care, deputy director from Levi Mwanawasa Teaching Hospital, and he's an endoscopist. So he can just share on that as we wait for Professor to come on. Dr. Bright, please.
Well, thank you very much for this opportunity and for the introduction. So for our patients, in most cases, we are dealing with patients who usually have advanced disease. Because of the setup, screening is not a usual indication. In most cases, the usual indication is perirectal bleeding. So when these patients come through, because of the education levels as well, we really have to spend time to explain to them how they should prepare, because bowel preparation is quite key to detection of lesions, as we've already heard. So the first thing we do is to explain to them what the procedure is and what to expect, and any possible adverse events that may take place. And then in terms of the laxatives, we start first of all with the dietary modification. 2 days before, we advise our patients to be on semi-solid food, such as mashed potatoes, yogurt, porridge, and so forth. And then the day before, we encourage them to be on soups and fluids, juice, and everything. And then they take the laxative, and mostly these are sodium phosphate-based laxatives. They take at about maybe 6 p.m. And we encourage them to take a lot of water up to about midnight. After that, they don't take anything until we do the colonoscopy the following morning. So usually these procedures are done before midday. So they would actually starve from midnight after having had a lot of water, and then they come through in the morning. Basically, that's mostly how we prepare these patients. But I must say, because of the education levels of our patients, except things are improving now, we tend to have quite a good number with poor bowel preparation, and repeat colonoscopies in most cases after patients notice that actually they need to do better, and then they have to come back again and have the colonoscopy done. So basically, that's a summary of how we do bowel preparation in our country, and specifically at Levi Manawasa University Teaching Hospital. Thank you very much.
Thank you very much. So we'll move on straight away to our next presenter, Dr. Nurse Joel M. Podo, who is the founder and the chairman of the Society for Nurses in Endoscopy and Minimally Invasive Surgery, SNEMIS, Ghana. So Nurse Podo, you have the floor. Sorry, we can't get you. It's like you're muted.
Okay, can you hear me now?
Yeah, sure. Thank you.
All right, thank you very much. So a lot of literature has been displayed already on this thing. So I'll go straight to practically what we do here in Ghana. Most of the times, or most of the bowel prep agents that we use are the isosomatic agents, talking about the polyethylene glycol, the PEGs, right? Okay, so the whole idea is to clean up the bowel, and so we actually developed the diet sheet for our clients, and as Dr. Harlem Richard rightly said, we give our clients a list of foods that they should avoid at least 2 to 3 days prior to the procedure. We don't want to starve our clients, and so we make them eat foods that would not produce bulk stool for the clients. And so as we give them this list, foods they should avoid, they shouldn't, and foods that they should eat, we go ahead to schedule them prepare them depending on their schedule. So if you have the morning patient coming for a morning appointment, the day before we instruct them not to eat anything at least 2 weeks before 2 hours before starting the PEG or the preparation. And so they can take those foods that are allowed, and then by 12:30 to 1, they should have their lunch and stop eating by 1 p.m. And then from 3 p.m., they begin taking the PEG. And this is a 2-liter solution that they have to take. We give them 4 liters in all, but they are supposed to take them in divided doses. So the day before the procedure, they start taking the 2 liters from 3 p.m. and they should finish that, latest by 9 p.m. on the night before the procedure. And they are allowed to continue to take in clear fluids up to 2 hours of their appointment. And then on the day of the test or the day of the colonoscopy, we still counsel them not to eat anything in the morning, and they should wake up at dawn around 4 a.m. to start taking the remaining of the 2 liters of the PEG. And after that, or in between that, they can still have just clear fluids. And then 2 hours strictly prior to the appointment time, they are not supposed to take anything by mouth. So this is for the morning appointment patients. And with this, we are able to have a clean preparation. All along, we've had very, very clean preparation with this regimen. Those coming for afternoon appointments, we also prepare them the day before the test. They do not eat anything at least 2 hours before starting to take the PEG. After they have been given, the foods that they can take and not take 2 to 3 days before the procedure. Then they can have their lunch, and then by 3:30 to 4, they can have the light diets as instructed. And then 4 p.m. they stop eating. 6 p.m. they begin to drink the PEG, and they take the first split dose, which are 2 liters of the PEG, and should finish that by 9 p.m. And then On the day of the procedure as well, no breakfast, and they can start taking the second split dose by 8 a.m. and then finish by 11. So from 12:1, they are ready to have their colonoscopy. So basically, that is how we prepare our clients here. Right. Thank you very much.
Thank you very much, Ms. Podo. Thank you for that brilliant presentation. Right now, we are going to listen to Nurse Johnson Ogundare. He's equally the founder and the chairperson of Cinemis, Nigeria. Sorry. So just a reminder that Nurse Johnson Ogundare have 2 minutes to talk about BOE preparation in Nigeria. Thank you.
Right. Thank you very much, Dr. Dave, and thank you very much, the other panelists. I want to appreciate Dr. Rich and the other presenters' presentations. And then, of course, Dr. Rich's presentation gave us enough insight into BOE preparation methods. And I want to join my friend from Ghana as well that we actually have similar ways of preparing BOEs for colonoscopy for our patients. However, in Nigeria, there is a variation in BOE preparation methods. So it depends on the facility policy, physician preference, and then of course, patient selection. So we need to put all this into consideration, and that is what we do in Nigeria, because we have various methods of preparing BOE for colonoscopy, based, like I said, based on patient selection, and sometimes our physician might prefer a low volume prep, and some might prefer a full volume prep, depending on patient. So, however, the most important thing from the nursing perspective is to provide that dietary modification, teaching, education to our clients to ensure compliance to whatever the physician might have prescribed. So here we depend on physician prescription and our patient selection, and for us to determine what particular type of BOE prep that we are going to use. I haven't mentioned that we have various laxatives that we do use in Nigeria. But traditionally, Nigeria prefer to use water enema, talking about enema. And in some cities, they will prefer to go for Ducolas, Bicolas, and some sorts, depending on cost of procedure. So all these have some effects on the type of BOE preparation we give to our patients to ensure that we have first a safe endoscopy and at the same time to protect our colonoscope, because bad BOE preparation might definitely impact the scope when it comes to the time for the processing of such a flexible endoscope, which is the colonoscope. So basically in Nigeria, we have various methods of doing it. And of course, they are similar to what other presenters have mentioned. And this has to depend on the endoscopy unit policy and patient preference and physician preference as well. Thank you very much.
Thank you, Ms. Johnson Ogundare. And just want to remind all attendees that we are soon moving to the question and answer session. And for all those who haven't sent in their questions, you have the Q&A box to drop in your questions. And for everyone with comments, you have the chat box to drop in your comments and suggestions. So we'll be getting to that in a bit. But before then, we will listen to Dr. Ahmed Selim, who is also going to discuss with us BOE preparation in Egypt. Dr. Selim, you have the floor. Thank you.
Thank you. Bowel preparation in Egypt maybe 10 years ago was based on water enema. Now the majority of preparation use macrogol, 2 liter 24 hours before the procedure. and the patient is encouraged to increase water intake and take clear liquid fluid. This is for morning scheduled procedure. Sometimes, due to the cost, if macrogol is not used, we usually use the magnesium citrate, which is widely available and cheap. Magnesium citrate can be used up to 20 gram for 24 hours before the procedure, and plus clear liquid diet 24 hours before the procedure. This is for bowel preparation in Egypt. Thank you.
Thank you, Dr. Ahmed, and a very big thank you to all our presenters for this wonderful session. I think it has been very informative, and many of us have had a lot to learn, and equally so many questions, as I can see from the Q&A box. Before getting to our questions, there was this question which was already answered by Dr. Harlan Rich. I'm just going to read it out. The question was asked by Olusola Ayedebinu, and his question was, are colonic polyps a sign of colorectal cancer? So the response from Dr. Rich was, many, but not all, colonic polyps are precancerous, but they are potential precursors to colon cancer. So that was Dr. Rich's suggestion or his answer to that question. Before moving to the next questions, I don't know if there's any other panelists who has something to say about this question. So I'll just repeat the question. Are colonic polyps a sign of colorectal cancer? Okay, seems like Dr. Rich's answer was enough. We'll move on to the next question by Lucio Santos. And he says, in Mozambique, the incidence rate of rectal cancer is higher than that of the colon. There are young patients, sometimes confused with anal cancer when advanced. Only the histology is different, as is obvious, and many patients are HIV positive. Is this also your experience? I think he was posing this question to Dr. Katzizira. So, Dr. Katzizira, I don't know if you have anything to say concerning this question.
Thank you very much. I think the thing to remember is that in young populations, right-sided or rectal and sigmoid cancers tend to be more common. If you look at the history of colon cancer in Western countries, there's been what was called a rightward migration of cancers over time. But having said that, we also need to remember that cancers in the rectum are easier to diagnose than cancers in the cecum, for example. And where colonoscopy is not easily available, you can get the erroneous impression that rectal or right or left-sided cancers are more common, simply because they're actually easier to diagnose. Sometimes all you need to do is to do a digital rectal examination. I hope that answers the question adequately. Thanks.
Thank you for that answer. We have a question in the chat box. This is by Grace Adeyeye, who said, well done, Professor Aletsi, an enlightening presentation. She wanted to ask, please, sir, what exactly is being measured in the urine for colorectal cancer screening? I've noticed that Prof is no longer on. I'm not sure if any of the panelists would want to take the question on what is being measured for colorectal cancer screening in the urine. Anyone? Okay, if not, we'll move on to the next question, which is on Facebook. This question is for Dr. Kadzira, which is from Tolam. She's saying, thank you very much for a great presentation. You mentioned that the colorectal cancer rates in South Africa is largely driven by the rates of Caucasian population. In the United States, we see higher rates in the Black African Americans compared to Caucasian population. Do you sense any? Do you see any difference from these two? That's her question.
Thank you very much. I think the first thing is to say, just mention that I didn't say the colon cancer risk in South Africa is driven by the white population mostly, but it's just that the incidence is higher. And South Africa is a higher proportion of Caucasian populations compared to other African countries. But in the Black population in South Africa, the incidence of colon cancer is just similar to what's obtaining in the rest of sub-Saharan Africa. Having said that, I acknowledge that colon cancer is a lot higher in the Black population in the United States. And what that tells you is the contribution of diet and lifestyle to colon cancer. And presumably, if Africans living in Africa maintain a shift towards the lifestyle and diet that is, for lack of a better word, westernized, we'll slowly see an increase in the incidence of colon cancer. But like I said, these shifts are likely to take a lot longer than we think. It's not something that's going to happen in a generation, but it's likely to be multi-generational. Thank you.
Thank you for elaborating on that answer. I'll go on to the next question. This one doesn't have a specified presenter to answer. So I think any of the presenters can go ahead and answer. So the question is coming from Trust Zarenyeka, who's asking, what specific advice regarding screening can we give our patients in our routine clinical practice? As an endocrinologist, I look after diabetics of wide range age who have animal-based diets on most parts of the urban setting. So what specific advice regarding screening can we give our patients in our routine clinical practice? That's the question. So any of the panelists can go forward. We can have Dr. Lewis Banda can go forward, any of the panelists. Thank you. The question is, what specific advice regarding screening can we give our patients in our routine clinical practice? Dr. Lewis, do you want to take that up?
Okay, yeah, I can try to shed something. Obviously, what we have noted, like in my hospital, is that the patients that are coming to us, mostly they are presenting quite late. You know, when they are already metastatic or the tumor has spread within the abdomen. So if we were to start screening for these people, even opportunistically, to help a lot to find those cases that are early and we can try to manage. For us, most of the time is that when we are doing our practice, we are so much about what we do, and we don't think of cancers. So what I can say is that for most of the doctors that are seeing patients, they should think of colorectal cancers, and our cancers, they start earlier than what is seen in the West. So what we should do is that we should encourage these people when they come, when we are seeing these people, to try to start testing for colorectal cancers. And it's something that we have not done very well in, and that's why we are ending up with those cancers that are already metastatic. So like my patients, most of them, over 60% are already metastatic by the time they come. And we need to change this scenario if we are going to save people. Thank you.
Thank you so much, Dr. Banda. Dr. Rich, would you want to add on to his comment as well on what advice you would give?
Yeah, I think that you have two major issues. One is that you need to show that the screening is actually going to reduce the mortality. And obviously it's going to reduce the mortality by trying to find cancers at an earlier stage, or in the case of polyps, removing polyps and actually preventing them from growing to become cancers. In the United States, where there's been a fairly concerted effort to do colon cancer screening, most insurers have been paying for it since the early 2000s, the incidence of colon cancer has dropped in half in our population. So I was actually very interested in hearing the results of the FIT testing program that one of the other presenters had discussed, because we've done this in our clinic, and our rate of detection of adenomas and advanced adenomas was as high as 40 to 60%. And there were a few cancers that were detected as well through the FIT testing. So I think, you need to show that the testing is going to be useful in your population. So I was dismayed a bit that that FIT testing program was not so successful. And that obviously, if you can detect cancers early, or if you can find polyps and remove them, that you can reduce mortality. The second issue is resources. You can't widely recommend a screening program unless you have the resources to manage it. And even in the United States, which is resource rich, we have populations of patients who don't always have the same access. And in those patient populations, we are using FIT testing more widely. But again, with the understanding that in our populations, FIT testing has been shown to help identify both cancers at an earlier stage, if done in an asymptomatic population, and advanced adenomas, which we can then remove and hopefully prevent the progression to colon cancer.
Thank you, Dr. Rich, for the response. We have another question from Jigme Doji, and I think this question equally goes to Dr. Rich. It says, is there any role of imaging for screening colon cancer? So is there any role for imaging in the screening of colorectal cancer?
It depends upon if you ask a gastroenterologist or a radiologist, but yes, there are screening programs that have been done with CT colonography. CT colonography is a form of cancer screening that some societies recommend. It's not recommended across the board, partially because there's no prospective long-term data showing that it will reduce colon cancer mortality, but there's presumption from the findings and the specificity and significance of the findings that it'll do that. It's somewhat expensive. It probably needs to be done every 3 to 5 years, and it does expose the patient to a modest radiation dose, which then increases cancer risk as incremental amounts. So it's not widely being done in the United States. And again, you have to have access to CAT scanning equipment to do that. In the good old days, people did barium enemas, but again, I don't think anyone is really doing that for screening at this point.
Okay, thank you very much. The next question, I think I will direct this to Dr. Sokolo. It says, in the absence or unavailability of colonoscopy, how would you diagnose bleeding caused by colorectal cancer as opposed to bleeding caused by other conditions like hemorrhoids?
Sorry, I didn't quite get the question.
Okay, I'll take it over again. It says, in the absence or unavailability of colonoscopy, How would you diagnose bleeding caused by colorectal cancer as opposed to bleeding caused by other conditions like hemorrhoids?
All right, thank you very much. That may be quite difficult to make without colonoscopy. If you can't do colonoscopy, probably the other thing you can do probably is to do imaging. If you can do a CT scan of the abdominal CT scan with contrast, you may be able to pick the mass, especially if it's on the bigger side. But basically, it's quite difficult to make, or maybe even maybe doing tumor markers as well. But the best thing is just to do colonoscopy. Thank you so much.
Okay, thank you, Dr. Sokolo. The next question, I think I'll still direct this to Dr. Rich. This question is from Grace Adeyeye, and she's asking, what determines if a patient with suspected colorectal cancer will have PEG or enema saponis as the method of bowel prep for colonoscopy? Dr. Rich?
Yeah, I think the question really relates to whether or not there's any sign of obstruction from a cancer. So obviously, if the patient is obstructed and you tried to give a large volume of fluid above the obstruction, you could wind up causing bowel distension, pain, and potentially, because PEG in particular is non-distensible, you could even potentially cause a perforation. So if there's a suspected high-grade cancer, a high-grade stenosis, you probably would only want to give enemas or some type of distal type of preparation. But most cancers are not obstructing. And so if there's no sign of obstruction, you could probably use polyethylene glycol without any difficulty or concern.
Okay, thank you, Dr. Rich. So we have just about 8 minutes left, but we try our best to take all the questions. Before going to the next question, I think I would like to hand over the floor to Dr. Comfort.
Thank you, David, for that. We just have on the other side, we have 2 more questions, and then David will continue with the other questions. So I think this question can be tackled by Dr. Ahmed. The question is, my question relates to histological assessment of large volumes of polyps that come from bowel screening endoscopy services. What preparations are being made in manpower training? If it's not here, Dr. Rich or Dr. Nsokolo can also talk about this. Thank you. Dr. Rich?
I'm sorry, I missed the question.
So the question relates to histological assessment of large volumes of polyps that come from bowel screening endoscopy services. What preparations are being made in manpower training?
You know, again, the United States is a fairly resource-rich area, so I don't know that the answer that I can give would be helpful to somebody in Africa. The other thing is that in the United States, most pathology is paid for on a fee-for-service basis. So if you generate more volume of material, you're generating more billing and charges, and you can pay for more staff. But I don't think that that's going to be an adequate answer to manpower training in a resource-poor area.
Thank you. Dr. Nsokolo, would you have an answer to that question with regards to Africa?
Well, to be frank, I think that on this side of the world, I can't see much happening. Firstly, because endoscopic services are not so readily available. And then even when it comes to staging where you're supposed to use the NBI staging, you find that the scopes that you're using may not even have intensified imaging. So not much really is being done here. And basically the few people that are able to do good colonoscopies are quite few. And we just really depend on pathology, just the histology. Just do your biopsies and have the histology done. And in terms of training, not much really has been set up here And people like myself, I had to go and get trained elsewhere in Asia to come back and have that skill to do colonoscopies that can really help patients. So not much is being done. We hope that in future a lot can be done. Thank you.
Thank you. A quick question from Moses Barasa. This is to Dr. Abid, and he's asking if you could comment on the pre or bowel preparation for colorectal cancers surgery in Kenya, to be specific.
Thank you
is
for
Dr.
that question.
Abid still here?
Yeah, I'm here.
Yes, he just wants the preparation for Kenya.
So it's not really a Kenya issue. I'll say there's evidence out there that bowel preparation helps surgeons before surgery, and there's evidence that says that it doesn't work. So it's kind of a surgeon's preference thing. I will typically do bowel preparation. It makes my surgeries much easier. It's almost like we do a bowel preparation for colonoscopy. Especially if you're doing a minimally invasive procedure like a laparoscopic colectomy, it is easier to handle the colon when you have a liquid stool within the colon than having a very heavy stool. Even your anastomosis becomes much easier. Most places they will do bowel preparation, but there's no strong evidence for it. But I think it's a surgeon preference.
Thank you for that clarity. I'll hand over to David to just ask 2 or 3 more questions before we close the meeting, because we only have 3 minutes to go. Thank you.
Okay, thank you very much, Dr. Comfort. The next question rapidly, and this question is addressed to Dr. Banda. What is your advice on the role of colostomy before adjuvant chemotherapy in stage 3 rectal cancer with no obstruction? Dr. Banda, have you anything to say?
Yeah, I can say something. Thank you very much. You know, it will depend on the circumstance. You know, where is the tumor located? If it's in lower down and there's a lot of obstruction, I think there's the colostomy is indicated. But if it's in the upper third, mid third, I don't think it's really necessary to do a colostomy at that point in time, because what is known is that for those patients that have ended up with a colostomy, you cannot reverse it after surgery, and we should try to avoid as much as possible to do colostomies in those cases where we want to you know, if a patient has to end up without a colostomy. And this is what we are trying to avoid as much as possible in most cases. Thank you.
Thank you, Dr. Banda. The next question, is rapid bowel transition time of any benefit in terms of avoiding colorectal cancer, considering the fact that consumption of fiber-rich diet and peppered food increase the frequency of bowel preparation? So I'll just take that again. Is rapid bowel transition time of any benefit in terms of avoiding colorectal cancer, considering the fact that consumption of fiber-rich diet and peppered food increase the frequency of bowel motion? I think Dr. Sokolo, do you have anything to say with respect to this?
Sorry, I missed part of the question. My apologies.
Okay, I'll take it again. Sorry. Is rapid bowel transition time of any benefit in terms of avoiding colorectal cancer, considering the fact that consumption of fiber-rich diet and peppered food increase the frequency of bowel motion?
Well, I've not come across any studies that have shown that that may be of benefit. So really, I wouldn't say that it's of any benefit. Other risk factors, yes, we are aware, but high fiber diet being of any benefit, I've not come across any study like that. Probably, maybe others who may have come across one may say something. Thank you.
Thank you, Dr. Sokolo. Dr. Rich, have you anything to say?
I haven't seen anything specifically on bowel transit time as a risk factor. Certainly, the types of foods in that diet may alter the microbiome. We do think sometimes that stasis is an inflammatory process, but it's not really clear that that plays a role. So I think more likely that that diet probably has a role in the microbiome and progenitor risk factors for changes and alterations in genetics and things in the bowel, but not really clear the transit time itself has a role.
Thank you, Dr. Rich. What about you, Dr. Banda? Okay.
I'm not so sure about that one myself.
Okay. All right, thank you. There's this question from an anonymous attendee who says, who gives the chemo, the surgeon or the physician? But I think Dr. Akwi already responded, and she says the oncologist makes recommendations for chemo. The surgeons are usually involved in the operative aspect. So I think that is all. I don't know, Dr. Comfort, do you have any more questions?
We close with one interesting question specified for Dr. Banda. He or she says, thank you, Dr. Banda, for the insightful presentation. I am a patient at CDH, and interaction with other colorectal cancer patients confirms that many patients report when the cancer has spread. My question, in addition to your comment to screeners in hospitals in the Ministry of Health or Cancer Disease Hospital, is the Ministry of Health or Cancer Disease Hospital generating any screening portfolio to implement nationwide to detect colorectal cancer in its early stage?
Okay, thank you very much for that question. At the moment, we don't have a nationwide program on colorectal cancer. We've done well with cervical cancer, and also we are trying to get early diagnosis for breast as well. But for colorectal cancer, we haven't done so well. It's something that we are planning to do going forward. Remember that we had the National Cancer Control Plan, which has come to an end, and we are trying to redo it. And that's one of the cancers. Colorectal cancer is one of the cancers that we want to add to the portfolio of those that we want to expand to the at national level. So it's about looking at the whole cancer picture in Zambia. Mostly it has been cervical cancer, breast cancer, and we concentrated so much on cervical cancer in the initial National Cancer Control Plan. But going forward, we need to add, obviously, colorectal cancer to the portfolio. Thank you very much.
Thank you so much, everybody. We'll just hand it over to Dr. Akwi to give the closing remarks. But personally, I have learned so much, and I have always had a passion to be a gastroenterologist. So you have all inspired me. I hope to meet you one day and to continue mentored by this team. I'm so grateful. Maybe David will say something. Dr. Akwi comes on as well.
Actually, I also like to thank everybody, and as Dr. Comfort said, I'm also passionate about gastroenterology, and particularly with GI cancers. So I think most of you have, in fact, all of you have actually inspired me a lot, and I equally look forward to meeting all of you in the future and working together and publishing and updating the data on colorectal cancer in Africa. So thank you all very, very much.
All right, so yeah, thank you everyone, very, very much appreciated. On behalf of the Pan-African Organization for Health Education and Research, we're absolutely grateful for your time, absolutely grateful for your presentation. And as Comfort and Dave have said, these are our future gastroenterologists, so we'll continue to support them. You guys did a fantastic job. I appreciate your time on personally, especially on Saturday morning, afternoon, evening, wherever you are. And to the attendees, we know there are a lot of questions that were left unanswered, but we are really tight on time and we have to be respectful. So, you know, granted, this is Colorectal Cancer Awareness Month. Any screening is better than no screening. I always tell patients about preparation sucks. That's the worst of it. But if you look at the end result, it's totally worth the time and the effort. It's important for you as an individual. It's important for your family. It's important for those around you. It's important for your community. I think within the African continent, we do have a lot of work to do, but this is a great start. We've got brilliant minds on this forum right now. And this was, we've got a lot of texts and chat messages and Facebook, et cetera, coming through. We cannot answer those because of time, but this has been really, really informative, and I cannot thank you enough personally and on behalf of the board. And I'll just take this opportunity to put in a plug for Dr. Katsitsira. He's actually going to be presenting at Grand Rounds as part of the Brown University Grand Rounds next week. I'll try and post it on my personal page. That's like a personal plug that I'm putting in there. So we're excited to have him, and he's going to spend an hour just talking about colorectal cancer in Africa, you know, giving us more information. So I'll try and share that with you for anyone who's interested in joining and just kind of learning more about colorectal cancer at the Brown University Grand Round. So once again, thank you all for your time. Very much appreciated. Wonderful presentations. And thank you to all the supporting organizations. Thank you to Brown University. Thank you to SNEMIS Ghana, SNEMIS Nigeria. And thank you to the World Endoscopy Organization for your support. And thank you to the American College of Gastroenterology for your shout out and helping us get the message out. So once again, colorectal cancer is preventable, it's treatable, and it's beatable. So know your risks, ask questions, get screened, and any screening is better than no screening. Blood and stool is not always hemorrhoids. So think of the broad differential, you know, when that happens. All right, thank you so much, everyone. Have a fantastic day. And our next program for POHER is actually tomorrow for the scholars. For those who are pursuing a master's in public health or PhD, just looking for funding, that's happening tomorrow. So take good care, everyone. Have a fantastic day, fantastic weekend on behalf of POHER. Thank you, signing out.
Thank you. Bye.
Thank you, Akwi. Bye-bye.
All right. Thank you all.
Bye.
Thank you. Bye.